Good evening. I am Nicole Jackson Williams, first Vice President of Alpha Kappa Alpha Sorority Incorporated, Xi Omega Chapter. It is my pleasure to bring you greetings on behalf of our President, Raven L. Hill, and our 650 plus members. Welcome to our guests who have joined via Zoom or Facebook Live in our observance of Triple Negative Breast Cancer Awareness Day. Why is it important to develop an awareness about triple negative breast cancer? About 10 to 12% of all breast cancers are triple negative. Triple negative breast cancer tends to be more aggressive than other types of breast cancer. Within the African American community, African American women are twice as likely to be diagnosed with triple negative breast cancer compared to white women. Additionally, African American women who are diagnosed with triple negative breast cancer are 28% more likely to die from the disease compared to white women with the same diagnosis. Although these statistics don't seem favorable, we all have something within us that is called hope, and hope is a very powerful force. Hope, coupled with the spirit of survival, allows us to fight like a girl to survive triple negative breast cancer. What does it mean to fight like a girl? Well, girls are very strong and they never give up. This fighting spirit of hope is what allows us to fight triple negative breast cancer and win. The inspiration behind this webinar is hope, the faith of our survivors, and many more medical tools in our arsenal that will help us to win. Our webinar will allow us to hear the survivor stories and to see the faces of triple negative breast cancer and to receive expert medical advice. I will leave you in the very capable hands of our two moderators, Tanya M. Brown and Desiree Medina. Tanya M. Brown is a native Washingtonian and the target lead for Xi Omega's Women's Healthcare and Wellness Breast Cancer Awareness and Care for the Caregiver Committee and has served in this role for the past 3 years. She has also served as a facilitator for Monday Activities, Xi Omega's longest running program for senior citizens. Tanya is a graduate of University of Maryland College Park, the George Washington University, University of Phoenix, and is currently a doctoral student at Marymount University in Arlington, Virginia. Professionally, Tanya is an associate professor of psychology with an expertise in human development, founder of Professor Brown LLC, and the author of There Is Nothing You Can't Do Free Writing Journal. Our second moderator, Desiree Medina, is a graduate of Howard University, where she received her bachelor's degree in public relations. She has been a member of Alpha Kappa Alpha Sorority Incorporated since 2003 and serves as Xi Omega's Sisterly Relations Committee Chairman, as well as Target 2 Breast Cancer Awareness Subcommittee Lead. She is the publicist for two-time Grammy-nominated and platinum-selling rapper and producer Havoc from the group Mobb Deep, battle rapper and podcaster Math Hoffa, as well as other artists and entertainers. So welcome to our moderators, and I will now turn it over to you all.
Thank you. Thank you. Good evening, everyone. Our first panelist is LaToya Bowles Johnson. She is a certified and specialty board certified emergency medicine physician assistant with a decade of clinical experience. She is a proud graduate of 2 HBCUs, including Prairie View A&M University in Texas and Howard University. She is a wife and mother of 3 little girls under the age of 6. Mrs. Bowles Johnson was diagnosed with stage 3 triple negative breast cancer in July 2021 at the age of 36 years old. After that point, her life shattered. She works hard to make a negative into a positive by promoting self-advocacy and breast cancer awareness, specifically targeting the young African-American female population. She is the owner and founder of the Tatas 365 LLC with nonprofit designation pending. Welcome, LaToya Bowles Johnson.
Thank you so much for having me here tonight. I really appreciate it.
We also have with us Dr. Regina Hampton, a familiar face at our panel discussions. She is the medical director of the Breast Care Center at Doctors Community Hospital, the first breast care center in Prince George's County, Maryland. She is a board certified general surgeon who has focused her practice on breast health and breast cancer. Her former private practice, Signature Breast Care, was the first breast surgery practice in the county. She is also a certified mastectomy fitter. Dr. Regina Hampton is the medical director and co-founder of Breast Care for Washington, a nonprofit dedicated to providing access to mammograms regardless of the ability to pay. She was the project director for a Susan G. Komen $1 million grant that provided mammograms for uninsured women in Prince George's County. She completed research at the Georgetown University Lombardi Cancer Center, which was published in Oncogene. Dr. Hampton has been featured in many local and national television and print media outlets, including but not limited to NPR, the Washington Post, Essence Magazine, and the Russ Parr Morning Show. In October 2018, she opened Cherry Blossom Intimates at Woodmore Town Center in Prince George's County, Maryland. It is a bra boutique offering custom prosthetics for breast cancer survivors and lingerie for all bodies, shapes, and sizes. She is a proud member of Delta Sigma Theta Sorority Incorporated. Welcome back, Dr. Hampton.
Thank you. Good evening, everyone.
So we're going to jump right into it. I am very excited about tonight. So we want to welcome you, Mrs. Bowles Johnson, and we're going to dive right in. So you had a 1-year-old that you stopped breastfeeding 5 or 6 months prior to your diagnosis. You thought you just had an enlarged milk duct. What was it that made you actually go to get checked out?
Well, I felt the lump like around May, June of 2021, and it wasn't going away. And that's what made me feel, okay, I need to get this checked out just to make sure that I am just dealing with something more of a benign nature. And I just kind of had a video visit with my OBGYN, and she ordered the mammogram and the sonogram.
Okay. And what were your first thoughts after receiving your diagnosis? What was running through your mind?
So just to rewind a little bit, I going into having a mammogram and sonogram, I did not think that this would be, malignant. Thinking it's, maybe a fibroadenoma or, galactocele. Those are more benign conditions that I'm thinking that this could possibly be. And I was actually misdiagnosed initially. The radiologist read it as a galactocele, and actually I had to push for still receiving the mammogram because the tech was like, hey, let's just wait a moment because, you just stopped breastfeeding and you're 36 years old. I don't think the radiologist wants to go ahead and proceed with the mammogram. So I had to push for, still going through with the mammogram. And I saw the lesion myself there as well. And I was actually misdiagnosed as having a galactocele. It wasn't until 2 days later when another radiologist called and said, I think the margins look suspicious and I'm recommending a biopsy. And at that point, my heart just dropped because I knew what that, possibly meant.
Okay. So being that you are a physician assistant, did that make your diagnosis a little bit easier for you, or was it harder because you know what that entails?
I think it made it harder for me. I mean, I don't think that receiving a breast cancer diagnosis is easy in any form. But it definitely played on my, mentally. I felt as though, how can I miss this? Like, how did I miss this? Even though oncology or breast oncology is not my specialization, like my specialty is in emergency medicine. So I'm, fixing ankle, popping ankles back into place and, putting stitches in people's foreheads all day. So this is not my specialty. So it did make it more difficult for me because I never saw myself as being the patient. So this is still something that I'm struggling with because being a patient just makes me feel a bit defeated. It makes me feel like vulnerable, like I'm supposed to be the provider. I'm supposed to be the one that's taking care of people and patients. I'm not supposed to be the patient. So this has definitely made it more difficult for me in that regard.
Mhm. And can you walk us through the timeline of when you were first diagnosed and how your treatment unfolded?
Um, so as I was saying, so I had the mammogram and sonogram, was misdiagnosed. The second radiologist recommended a biopsy. So went in for the biopsy. Due to COVID restrictions, my husband was not able to stay back there with me. So this is another thing with COVID is causing another layer of detachment from humanity, dealing with this. Um, and it, so I'm there, I was still saying to myself, okay, this is a galactocele. I'm still thinking that, okay, this is a milk cyst. This is just a milk cyst from breastfeeding. And when the radiologist was not able to aspirate any fluid, I knew at that point that I was dealing with possibly cancer at that point. I just started crying hysterically, just could not control myself. And after that point, I was told that I would receive a phone call in a couple of days with the biopsy report. I was actually working in the ER when I received a notification in my patient portal. I received a notification. So I just checked it. Didn't I think that this could be a cancer diagnosis report? Checked it, and I just couldn't believe that it said triple negative. I'm reading it and I'm understanding the pathology report, but initially I'm thinking this is an error. This is not from me. This is not, no, they've made some type of error. There has to be an error. Um, and dived into it more and looked into the report. I was working with, my attending physician at that time, and my coworker, my supervising physician, and I asked him to look at my report too, because I just could not believe what I was reading. And he confirmed it. He confirmed, like, this is it. And because of the law changes, unfortunately, patients are entitled to, it works in an unfortunate matter in this regard. Because whenever there are results that are available, patients are receiving these notifications, and sometimes the physician has not even seen the results before the patient receives it. And this is exactly what happened to me. And I think for things such as cancer or, HIV notification or something of that nature, it just needs to be more, not in a setting like that, not receiving, a notification on your phone. It's just inhumane to receive a devastating diagnosis in that manner. And when I received it, it was at 4:30 in the afternoon. So I'm trying to call, my physician office. No one is there. um, it wasn't until the following day I received a phone call from the radiologist, just basically confirming it. And it was very dry. It was a very somber, notification, and that was it. So it was devastating when I received the when I received the notification on my phone and read the pathology report, and um, I had to leave work. I had patients that I was doing the laceration repair, and I had to leave work. I was not functional at that point to mentally be able to take care of any other person and have their lives in my hands. So I had to leave work. And when I pulled up in the driveway, my husband knew that I was home early. I worked 12-hour shifts, and it was the middle of the day. And when I pulled up, he just passed out in the driveway because he knew that this was cancer. He knew that's what I came home, early for. So
Mm, that is a lot. Um,
yeah.
Thank you. I know that has to be tough, just reliving all of the emotions that you felt from that. Did your doctor recommend any support groups or anything to help you cope with your diagnosis?
Yes, so I did receive, when I had my first appointment, it was more of a multidisciplinary appointment. So I met with the medical oncologist, the radiation oncologist, the surgeon, as well as the nurse navigator and therapist, all in one appointment. So it was pretty overwhelming. Thankfully, they allowed my husband to come to that appointment. Um, So yes, they did give like some paperwork resources, and the nurse navigator is the one who was really more so focused on mental health. She's very, very sweet. I love her to death. And she was the one who was really pushing for it. Listen, you need to make sure you have mental health support and resources. But it was so much information that I really didn't, comprehend everything at that one time because it was just a lot. It was a lot. So I actually did not set up support initially. That came to at a later point.
Okay. And what treatments did you receive, and were there any side effects to the treatments?
Oh yeah. Oh yeah. So I received initially the red double. So I received the adriamycin and cytoxin for those 4 cycles. I received the standard neoadjuvant chemotherapy. I finished with 16 cycles. My last cycle was January 5th of this year. Adriamycin, the red double, that's the one that like makes you lose your hair. After like the second um, treatment, my hair was just falling off. Um, my husband, that was hard for him. That was hard for myself. My kids were traumatized with, my hair loss. And it's not just your hair on your head, it's complete body hair, your eyelashes, your eyebrows, everywhere, your body hair, everything falls off. Nausea, dizziness, fatigue, shortness of breath. It changes your taste buds. Everything tastes metallic to me. It changes my fingernails. My toenails are black and brown. The palms of my hands and my feet are darkened from chemo. Even though I finished chemo about 8 weeks ago, I still have residual side effects from chemo. Nosebleeds. Every morning my nose bled. I had constant nosebleeds. It sent me into medical menopause at 36 years old. So I didn't have a cycle. I haven't had a period since chemo started, and it caused me to have hot flashes now as well. 1 minute I'm hot, 1 minute I'm cold. I have like, sometimes I feel like I have lost the sensation, or, not as prominent as like neuropathy, what a lot of women may experience, or even post chemo. It causes a lot of effects, swelling of the hands and the feet. And on top of that, you're receiving steroids, which causes more fluid retention and weight gain. And you're having to receive injections after chemo as well. So every day, my husband had to, inject me as well with different to stimulate my bone marrow. The first one caused me to have a syncopal reaction, or I passed out and I had to be hospitalized overnight. I was hypotensive with low blood pressure. So it caused so many side effects. And after I got through the Red Devil, that 4 cycles of Red Devil, I received paclitaxel, and that one, I did better with that one. I did much better with that one. The side effects, subsided a great deal. I still had some, but I was going every single week to chemo, and it just, it makes you feel loopy, fatigued a lot. You just don't have lack of energy. So it causes a great deal of effects of, different changes on your body.
My goodness.
Yeah.
It is a lot.
Yeah.
And that's a lot, but you also have your mastectomy tomorrow. So,
Yes. Yeah.
you just describe to us how you're feeling, or how you're feeling right now, seeing as it's tomorrow.
I am, I'm human, right? So I'm nervous about it. I've never had a major surgery in my life. I've had 3 babies, all natural. I didn't even have an epidural, my last baby. So they came too late. So I felt every contraction. So this is It's very, I'm just nervous about it, but I have faith. I have faith that it's going to go well. It's going to be uneventful. The Lord is going to guide the surgeon's hands with precision, and it's going to go well. Anesthesia, they're going to do what they need to do. I'm going to wake up fully recovered. And that is just what I have to go on at this point, because I know that it's necessary for me to have this mastectomy, and I am electing to have a double mastectomy. So I'm having both breasts removed. And in addition to that, I will have to have some lymph nodes removed because I am stage 3C. So my breast cancer type is, I am triple negative, invasive ductal carcinoma. So that means that my cancer had spread into my lymph nodes, multiple lymph nodes. So I know that I would have to have multiple lymph nodes removed. And but it's going to be okay. It's going, I just want to be alive. So it has to happen. My boobs are trying to kill me. So the boobs have to go. They are evicted, and I can get some more boobs from the belly fat, the back fat, wherever. The surgeon can reconstruct it. She can take all the fat that I have and reconstruct whatever it is that she needs to reconstruct. But these boobs, they are evicted and they have to go. So bye, Tatas.
Speaking of Tatas, I mean, we love your positivity. But speaking of Tatas, can you tell us more about your company? Like, what drove you to create it, what the process entailed, and what services you provide?
So it's very new. So I'm still in early development. So basically in September, after dealing with my diagnosis, like I said, I was diagnosed in July, and in September, I said, okay, after I processed it, because it took me a while to process that I actually have cancer. I actually have a port in my chest. Like, I actually have cancer. For me, when I discuss about feeling defeated and the vulnerability of it all, I have wanted to take care of patients since I was 4 years old. So I knew when I went on a field trip to Charity Hospital in New Orleans, Louisiana, where I'm from, I wanted to be a doctor. I wanted to be a doctor. I wanted to be OBGYN. I wanted to be a doctor. And then things kind of changed when my sophomore year of college at Prairie View, I met a PA. And due to like personal family situations and Hurricane Katrina, I was looking for a way to finish school quicker, but still able to take care of patients. And so I decided to go the PA route. But my dream was always still to go to medical school and be a physician and be an OBGYN. So this is a way for me to, get back to taking care of my family earlier, my siblings or whatnot. So that was the route I went. And so for me, not being able to take care of patients, it really drove me insane. You're talking about I worked, frontline during the pandemic. It didn't scare me. I was pumping while I was there, while I was working. I mean, I came back from maternity leave in February of 2020, and the pandemic hit March 2020. And during that time, I was still pumping milk for my newborn baby at that time, still working in ER. But I say all that to say that I decided to, okay, I'm at home. I can't work because I'm on chemo, and I can't work in the emergency department because I'm immunosuppressed. How can I still help people from home? So I started just posting videos, telling people about my diagnosis and letting women know who look like me that, you do not wait until you're 40. You need to make sure that you are checking your breasts now. And if you're high risk, you need to get earlier mammograms. So that is what I decided to do by just posting videos. And God just kind of spoke to me and said, hey, we need to be aware of the Tatas 365 days a year, and not just in October when, all of these companies are just suddenly, let's just do pink October and that's it. No, breast cancer affects us 365 days a year. So I felt as though doing some type of social media advocacy and posting videos, and women started reaching out to me that, okay, I found my niche and this is how I can help women I felt as though, okay, now I can help more than 25, 30 patients a day that we may typically see in ER. Now I can post videos and reach more women through that platform. So that's how that was evolved.
Well, we love it. And I hope that you can see all of the love being poured out to you in the chat. There's so much love and support for you for tomorrow and just for everything that you're going through. And we will speak to you a little bit later for our question and answer session. So, but I
Absolutely.
hope that you can view all the comments to you, all the love in the chat.
Yeah, I'm seeing it. Thank you, everyone. I appreciate it.
All right. So we're going to turn it over to Tanya Brown.
You, Desiree. And thank you, LaToya, for sharing your story. We are praying for you and cheering for you as well. Dr. Hampton, welcome back. It is a pleasure to share this experience with you again. We've done many events together, and let's just kind of scale back to a very simple question. Can you share with our audience what is triple negative breast cancer and how is it different than other types of breast cancer?
Yeah, thank you. So good to be with you again as well. So triple negative breast cancer, I think the best way to explain triple negative is to talk about a positive. So there are cancer cells that can use our natural female hormones, estrogen and progesterone. And those cancer cells like to take in our hormone and use them as its food for growth. And then there can be a third protein called the HER2 protein, which can tend to make cancer cells more aggressive. When a patient has that hormone positive tumor, then they're eligible for a pill type of treatment. And it's a long-term treatment. And we kind of call it a maintenance because we're going to give it to women after they've completed surgery and or radiation and or chemotherapy. And we're going to leave them on this medicine for 5 years. And what it's going to do is help lower the risk of a new cancer forming over that next 5 years. And the good thing with those medications is that they're working so well, we soon will be announcing that it will be a 10-year treatment because we're just keeping more cancers away. Now, when we talk about triple negative tumors, these tumors, they could care less about our estrogen, they could care less about our progesterone, and it does not express the HER2 protein. So that's why we call it triple negative. Negative estrogen, negative progesterone, negative HER2. So these tumors are not hormonally driven. There's just something in the tumor that is feeding them internally and telling them to continue to grow, unlike our hormone positive tumors. So when a woman has a triple negative tumor, her most important treatment is going to be chemotherapy, just as we heard LaToya talk about. And we've started to, well, we haven't started, we now switch the order. It used to be these women would get surgery first, but now we know that chemotherapy is the most important treatment. So we want to get that medicine in first. And I always tell my patients, like, look, you don't need to be anywhere near my table. You need to be with the oncologist getting that chemotherapy, and I will see you on the back end once we've treated. The other good thing about the triple negative tumors is they tend to be some of the best responders to chemotherapy. So we can take patients that are a stage 2 or a stage 3, and many times we can convert them down to a stage 1, many times even a stage 0. So they respond really well to those treatments. And I think we're really making a difference in triple negative disease by just changing that order. And as we continue to follow, I think we're going to see that the survivorship is going to increase for those patients.
Thank you so much. Now, you gave us a lot of information. Can you just kind of scale it back a little bit and specifically share why chemotherapy is so important for triple negative breast cancer?
So because those patients cannot get the hormone medicine, so remember, they're negative for estrogen, negative for progesterone. So giving them a hormone medicine, it's not going to do anything for them. So the chemotherapy is the only thing that we have available that helps to treat those cancers.
Okay.
And the other unfortunate thing is, we don't have a long-term maintenance medication for those patients, which is quite frustrating for us. And so hopefully there'll be some smart research out there that will try and find a solution.
And what surgical options are best following chemotherapy?
So that really depends on a couple of things. It depends on the original size and stage of the tumor. It depends on the response. So there are a lot of patients where they could come in with, say, a 5 centimeter tumor, and then we go to do their surgery and there's nothing left. So I just in the past year treated my own practice manager, and she got a complete response. And so she chose to do lumpectomy, which is just taking the lump out, leaving the breast there, and then also taking some lymph nodes. But some women may choose to do a mastectomy, which is removal of the whole breast. And that takes a lot of different forms. It's not just one type of surgery. And then there are some women like LaToya who will choose to do bilateral or removal of both breasts.
Dr. Hampton, how do you help your patients to make the decision on having a lumpectomy or a mastectomy?
So the one thing that we do know in this day and age, when you do a lumpectomy and add radiation to it, it's essentially equal to doing a mastectomy. So there are two what we consider equal treatments. There's only about a 0.5, a 0.5% difference between the two options. So I think the great thing is women, for me, I kind of read the room and kind of see where she's at in her journey. It certainly takes a couple of office visits and conversations. There are some patients who they just know exactly what they want. They feel attached to their breast. They want to do the lumpectomy, and we say that's great. There are some patients like LaToya, and I know some of her breasties who are like, no, 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 they've got to go. So I think the great thing about where we are is that women have choices because 30, 40 years ago, there were no choices. Everybody got mastectomy, everybody got radiation, and everybody got chemotherapy. So the great thing is we're in an era of very personalized care. And so we can provide women with options and women can make the choice that works best for them.
Thank you. Why is breast cancer so different in Black and Brown women?
So the challenge with that is we tend to get more triple negative breast cancer. And then with that, just as we heard LaToya talk about, we get breast cancer at younger ages. So our white counterparts tend to get it over the age of 50, but we, about 30% more of us get it under the age of 50, and a significant number even under the age of 40. So 40 is when we recommend getting mammograms, but if you're in your 30s, you're not even at an age to get mammograms. And so it brings forth a challenge. I think in this area, and I guess for me, I'm just biased because most of my patients are African-American women. So, I'm just really tuned in and don't take a chance. But unfortunately, there are a lot of providers who don't treat that many African-American women and are not aware of the statistics. In 2018, the American College of Radiology and the Society of Breast Imaging, they're the ones who do the mammograms and the societies that control those. They deemed Black and Jewish women as high risk. And they are recommending that all Black women should get what's called a risk assessment starting at age 30. So all Black women should get a risk assessment at age 30. And what that means is that you go into a provider, a breast specialist. We're going to talk to you. We're going to dive in, see if there's any family history, look at the breast density. Might you be one of those lumpy, bumpy women where there's just always something going on? And maybe we might want to start to do screenings a lot earlier. So with that statement, it really allows us to be able to bring Black women in. I think the problem is we just haven't shouted this enough so that Black women get that message and spread that message so that they can come knock our doors down to come and get that assessment.
That would be wonderful. Early intervention is key. So when a young woman of color has a mother or a grandmother who is a breast cancer survivor or passed away from breast cancer, what age do you recommend that they come in for screening?
So we recommend starting 10 years earlier than the youngest woman. So if mom or grandma were 42, then we'll want to start screening the women in that family starting at age 30, no later than 32. And we're probably going to want to follow them very closely. We're going to want to do genetic testing. So genetic testing has really opened up as well. So we're going to want to just follow those women very closely. We probably will definitely get them started on doing mammograms, probably with ultrasounds, and probably adding breast MRI if they have significant density in the breast.
And what is involved, Dr. Hampton, with genetic testing?
So now it's just a saliva test.
Okay.
You just go into a doctor, just like any DNA test, and just kind of spit into a cup. It takes a couple of weeks to get the results back. What has changed in the guidelines, and this just changed within the last couple of months, is now they're recommending that all triple negative breast cancer patients, no matter what age, need to get genetic testing. So if any of you have moms, aunts, grandmothers who were diagnosed with triple negative breast cancer and they're now in their 70s, they should go and get tested, because this really can have huge implications on the family. We might be able to find some of those mutations and be able to take action on the women in that family earlier.
Thank you, Dr. Hampton. One of the things that we know is support and resources are so critical to our overall healing and success when we receive any sort of severe medical diagnosis. And you are one of the founders of Breast Care for Washington. What type of support services does your organization provide to the community?
So we are a nonprofit organization that is a mammography screening facility. So we offer 3D mammograms to women, whether they have insurance or not. And so for me, it was just important to really eliminate that as a barrier in our community. We're actually located in Ward 7 and 8. And so in this area, in the DC area, Ward 7 and 8 have some of the highest mortality rates from breast cancer. So for me, it was important to be able to put that right there in the community that could use it. We are a facility where for those young women, sometimes they'll go to other facilities and they'll say, well, you're not 40, you're not this age, you're not that age. We will get those women screened especially if they come in with a symptom, then we will do the breast imaging for those patients.
Thank you. And you're also the co-founder of Cherry Blossom Intimates. Can you tell our listeners about the boutique and what services that we can have there as well?
Yeah, so Cherry Blossom Intimates is a boutique located in Prince George's County. And so we offer items for breast cancer patients. So what a lot of breast cancer patients don't know is there is a federal law that protects you all. And what this law says is that you all have to be offered surgery, reconstruction, and that includes reconstruction on the side that has the cancer and reconstruction on the side that doesn't have cancer, because we can make you symmetric. And it also covers bras, it covers breast prosthetics. These are all covered by federal law, and insurance has to pay for those. And so we offer that bra, that prosthetic. There's some women who, even if they've had a lumpectomy, because they have radiation, they may have a little bit of shrinkage and have a little bit of asymmetry and be a little uneven. So we can supply bras and fit them with bras. And sometimes they need just a little sliver of a prosthetic just to even them out under their clothes. So that is available to all women. We also carry something called a custom prosthesis. So for any ladies on the call who been out and tried to shop for these items, usually they're going to give you just a pink prosthesis, which doesn't match many of our skin tones, or it's going to be just a plain brown prosthesis. So you can get a custom color matched prosthesis that really matches your skin tone, which I think is so important for women of color.
Thank you, Dr. Hampton. At this time, we're going to bring LaToya back in and Desiree, and we're going to transition to our question and answer segment, which Desiree will kick off for us.
Thank you. So let me look at our questions here. Right away, I see one for you. This question is for Ms. Bowles-Johnson. How can I support, or what do I say to someone just diagnosed with cancer?
the most important thing that you can say is just kind of just reassuring them and just letting them know that you're there for support, because initially we may we kind of blocking out, you know, some things, and just telling someone that don't worry about it is like the worst thing you can do, like, because that's impossible. Don't tell me not to worry about it. It's on my mind constantly. So just reassuring them that you're there for support and that, you know, you're going to get through this, but just letting them know that you're there is something that you can definitely can do.
I'll
Okay.
just also add to that. I think two things. A, come with something positive. I just,
Yeah.
Black
Yeah.
folks, let's be positive. No one wants to hear the sad stories when they just been diagnosed. So
Yes, it
let's
was a
come
Right.
with
lot of
some
that.
positive stories, first of
It
all.
was a lot of that, like, and that's the reason why I had to remove myself from, like, you mentioned about support groups initially, and I tried to join like a Facebook support group, and I had to get off of there because there was too many women on there talking about complications. Oh my goodness. And that just caused so much anxiety, and it caused me to be more depressed. And so I had to remove myself. And I'm glad that I identified that early, because that was, you know, that could definitely have complicated my mental health state even further.
I
Mm.
think I'll also add, everybody needs support in a different way.
Yeah.
So, not everybody wants you coming over, not everybody wants you cooking dinner for them. Give the survivor time to breathe
Mm-hmm.
and kind of process this for herself. Let her know that you're there, but you don't have to be all up on her. She just
Yeah.
needs space to breathe it. And people, their journey is so different. And
Yeah.
so I think really just respect the boundaries and just let them know, hey girl, I'm here. I'm just sending you a text to say I'm here. You don't have to respond, but
Mhm.
and let her reach out to you when she's ready.
Yeah, because I became overwhelmed. There was so many people, and I know that everyone means well, but there was so many people that was like, "Oh, call my sister, call my auntie, call my such and so." Just
Yeah.
like, I'm like, "Oh," like you said, Dr. Hampton, like, let me breathe, because I can't talk to everyone that who may have survived breast cancer or whatever, and then hearing from that person too may also add some more anxiety, because everyone's treatment path is different. So someone may have complications, I may not. Even though I went through all of these things with chemo, the side effects, I will still say, just working from in the ER standpoint, I came out of there with chemo more of a breeze in comparison to some of the patients that I've seen, with acute complications with chemo that I've had to treat in the emergency department. So I'm grateful for that. So my story is different with chemo versus someone else. So that's very important. Also, the worst thing you can do is like trying to identify, well, what did you do that caused the cancer? That was, or
Yeah.
or you got to eat plant-based now, or it's because of this and it's because of that. And I got so much of that, and that really tipped me over. So it's, it triple negative breast cancer, first of all, there's not a whole ton of research, especially including Black women. Black women only represent 3% of clinical trials, so how do we know how Black women are actually, being affected, how our bodies, our biology is being studied in these trials? The numbers are too low. I mean, there's not enough of us representing these trials. So I think it's important for that in that aspect.
Thank you so much. And our
Yeah.
next question, Dr. Hampton, is for you. Can you share for those individuals who are in helping professions, such as in the medical profession or mental health profession, how they can manage taking care of patients, as LaToya said, but also take care of themselves? So what are your self-care recommendations?
Yeah, I think, as women, we have to put ourselves first. And, we're all givers. We're, trying to take care of everybody. What I often tell my patients is say, look, maybe the family just needs to eat peanut butter and jelly tonight. Don't go running home trying to cook dinner. They'll be okay. They can eat cereal. So I think some of this, we have to just take that superwoman cape off. The family's
Yeah.
going to be okay. And we have to be willing to receive
Yeah.
the support. because again, we think, well, I don't want them to think I'm strong, but it's okay to sit back. And I often tell my patients, so I put in a medication. So my patients feel very good after surgery. And so I tell them, well, your family don't have to know that you feel so great. Go home and fake it. Tell them I just had surgery, and they're sitting there chilling, but they don't have to know that. So I say, we've got to put ourselves first, allow people to take care of you, because sometimes those who support us, that's all they know how to do, is to try and support you. So some of that we do have to, in some instances, step back and allow that to happen. And I think, learn the power of no.
Yeah.
It's got a capital, it's got a period, it's a complete sentence.
Absolutely.
And so I think we need to learn the power of no. And you can say it with a smile or not. But I think really just being selfish with yourself and your time. And sometimes you got to shut yourself off from your kids. Go into a room, light some candles, and read your favorite book, and be non-productive. That's okay. It's all right to do.
Thank you.
Exactly.
Desiree? Oh, I'm LaToya.
No, I was just gonna say that's been a challenge for myself. It's just like, just learning how to accept help, because I'm not the person that accepts help. So I think for listeners, for people on the call, like, just knowing if someone has cancer, sometimes it's difficult for me to ask you for help. It really truly is, especially with my character. So if hey, listen, I'll just come drop off some eggs and pancakes and set them on the step for you, or can I come help you fold your laundry, because I'm not going to ask you, but if that what my situation is and you're available to do it, just volunteer, because that is a huge barrier for, I can only speak for myself, is asking for someone else to come do something for you, because it does make you seem like, okay, I don't have it together. It kind of just adds to that defeat. Does that make sense? I hope I made that kind of clear. Yeah.
Very clear.
Okay.
That's right.
Jen, this question is for you, Ms. Bowles-Johnson. How has your postpartum journey been affected by your diagnosis, and what does support look like for you as you're raising your young children?
The postpartum, now my youngest, she's 2 now. So I would not be able to function without my husband. My husband folds clothes, he takes braids out, he washes hair, he's getting sippy cups, he does everything. So I cannot function without my husband. So he is definitely a rock as far as like caring for the girls and just his whole postpartum journey. But what I will say to women who are postpartum, in breastfeeding mothers, is that don't think that because you just had a baby or you're pregnant that you're exempt from developing breast cancer, because you're not. You're absolutely not. Postpartum breast cancers is a real thing. I don't know, especially up, it can go all the way up to 5 to 10 years, I think, Dr. Hampton. So just know that if you feel a lump, even when you're breastfeeding, don't think that, okay, it's just, this is just in the large milk duct or whatnot. If it's not resolving, or if it's painful, even if it's painless and it's not going away, you should definitely get it checked out by your physician, because it can very much well be cancerous.
Thank you.
Okay, so we have a question from Facebook Live, and it is: do you find we are currently experiencing culturally competent care as Black women in healthcare?
I'm sorry, can you repeat that again, Tanya?
Yes. Do you find we are currently experiencing culturally competent care as Black women in healthcare? I ask this after hearing how often Black women have to advocate for themselves after often being dismissed.
Yeah, I think the medical community really still has a long way to go. Yeah, I know that they're trying to address it. I think there's more attention to it now that we're, in the Me Too movement, Black Lives Matter. I think there's more attention to it, but we still have a long ways to go. I think we still have to get more providers that look like us out there. There still aren't enough of us providers. And I think, for those of us, we just can approach the care in a different way. I think I can just speak to my patients in a different way than, say, a white male or even a white female can. And I can just have that conversation because we have some shared experiences. And so culturally competent care, it's still a long ways to go. But I think, as patients who are consumers, you're paying for a product, you pay for your insurance, you have to pay your copays. We need to demand better care. And if you find that you're not getting the care, it's okay to go to fire your doctor. It's okay to go get a second or even a third opinion. And I even recommend that patients do that. If you're not feeling comfortable, don't feel like you're bound to stay with that provider.
Thank you. LaToya, can you speak to that from your experience of being a PA?
Oh, I 100% agree with that. Representation does matter. We do need more people who melanated, who look like us, to take care of patients. Systemic racism in the medical system is a real thing. I've seen it. I've witnessed it firsthand with, in places where I've worked. Yes, if you patients, first of all, you need to make sure that you're understanding your physician. If they're speaking in terminology that you do not understand, you need to ask them to explain it to you. That is your right. You need to understand what is going on with your body. They need to explain that to you in lay terms. And don't think just because they have, whatever the credentials or letters behind their name, they still need to make sure that it's relatable to you. So that is all about, what I would say about that as far as self-advocacy. And I also I sought out a second opinion as well. I just wanted to make sure that I was on the right treatment path. There's nothing wrong with receiving a second opinion, especially when it's your life, especially when you're dealing with something such as stage 3 cancer. So advocate for yourself. If you feel like something is not right, don't get intimidated by the fact that you're not a physician, or a nurse practitioner or whomever. Just know your body better than anyone. So make sure that you advocate for yourself if something doesn't feel right. Most women, we find our lumps on our own. It's not clinical breast exams. It's not, having screening exams. It's because of you touching yourself and you're checking your tatas. That is so that it starts with you. And that's where it starts.
Yeah.
Desiree?
So this question is for Mrs. Bowles Johnson. You mentioned risk. If you don't mind the participant asking, do you have a family history of breast cancer? If so, did your family members also have triple negative breast cancer?
So, Black families, we don't like to talk about our family health history. Mm-hmm. So, you just hear, oh, such and such aunt just died. You don't know what type of cancer. You don't know if it was cancer. You don't know if it was heart disease. You don't know. So I do not have a known, prior to this, I did not have a known family history of breast cancer. Otherwise, I would have been receiving mammograms at a much earlier age had I known that. It wasn't until after I was diagnosed that it came out that, oh yeah, your grandmother's sister had breast cancer, and this one had ovarian cancer, and the other sister had, this type of cancer. It was after the fact that it came out, and to this day, I still don't know what type of cancer my paternal grandmother died from. I know it was some type of gynecological cancer, but I don't know for certain because, no one talks about it. Everyone wants to keep it a secret. Oh, grandmother was bleeding, but they just hide it and she dies and you don't really know. So, we need to stop saying, oh no, don't say such and such aunt is in the hospital. Don't tell anybody. No, we have to stop that. As Black people, we have to stop that. We have to start being more open about what is going on. We need to start educating our family members and letting them know the risk of family diseases so that we know what to be on the lookout for so that we can get screened for certain things. I had the genetic testing done. I was negative, but that doesn't mean that it doesn't mean that I don't have a genetic mutation. It just means that maybe research hasn't caught up on my biology yet. or most Black women are biology. So we have to do better, Black people. We have to start talking about our family histories. We definitely have to.
You, Dr. Hampton, I see you shaking your head. You want to add something?
No, I wholeheartedly agree. I think we've got to bring it out of the shadows. I always hear patients, they say, yeah, grandma had one breast. And I'm like, well, grandma had cancer. Well, no, nobody said cancer. Well, guess what? Somebody should have said cancer, because that is a part of our health history that we need to know. So I think, we start getting back out and doing, cookouts and everything, pass around index cards, and everybody write down what you've been treated for in the last year or what and somebody get that and send that around to the family so that we can be aware, because name a disease, we're affected by it at younger ages. Heart disease, cancer, you name it, we're affected at younger ages. So we need to be aware.
Dr. Hampton, and the next question is for you. A young lady wants to know if she wants to be able to track clinical trials specifically relating to triple negative breast cancer, how can she do that? How can she get that information?
So the nih.gov has information on their website. One of the breasties has just started something called When We Trial. That's by an organization called Touch BBCA with Ricky Fairley. And their goal is really to try and encourage us as Black women to get involved in clinical trials. And what I'll say is that, we have to stop looking at clinical trials as, a bad thing or people are giving you medicine. So I'm in a clinical trial called the Wisdom Study. Now, I don't have to take medicine. I'm getting my mammogram, which I'm supposed to get every year. I send them my results. They send me a questionnaire 2 times a year. That's part of a clinical trial. So there's so many ways that we can be involved. And I think, yes, we acknowledge the past, but it's because of the past that the way we do research, the way we get consent for research has changed because of the atrocities of the past. So we've got to not be afraid of the past, and we got to look towards the future. And all of us here can be a part of that for our daughters, our sons, and future generations.
Desiree?
We have another question here, and this is for LaToya. What are some ways for friends and family to help survivors experience some normalcy? So it's hard to be normal when your friend is going through something that you're worried about for them. And what have you been your best experiences of feeling like you and not a survivor?
Well, so before I started chemo, my husband surprised me. He flew up 2 of my closest friends in Texas, and they came up and we kind of spent the weekend at the beach, and I felt normal. Like I love the water, so it was very tranquilizing for me. So I just felt really normal during that weekend, and just having like regular girlfriend time. I also felt normal for my birthday, having a birthday dinner, just being surrounded by, close family and friends. So just know that, we're still the same girl, we're still the same, we're still the same woman, just kind of talking to us about normal things. Sometimes those could be good distractions as well. I've had a lot of friends send me gifts and journals and different books and just ways to express those outlets, and also hey, come take a walk with me. I can burn some calories anyway. So just those normal pastime activities would be helpful.
Thank you.
Dr. Hampton, we'll give the final question to you. I follow you on social media, and you wrote throughout the pandemic that healthcare professionals did not have a day off. So can you share how the pandemic impacted your role as a physician in this specific discipline? And now that we're coming out of the pandemic, what is your hope for the future?
So for me and my specialty, we were limited in that we really had to shut our offices down. We had to shut our offices down as clinicians. The mammography sites shut down. And so what happened is we ended up with this backlog of patients who we had to get caught up on. There were patients who, got their mammogram late or were afraid to go and get their mammogram because of the pandemic. They were worried. I even had people refuse to do surgery because they were afraid to come into the hospital. So, now that we're over that hump, we're trying to just get everybody caught back up and kind of get back out the messaging, that we had, that mammograms save lives. I'm still a big advocate for breast self-exam. I think women should be checking their bodies. I know if you look online, they've kind of debated this in the medical community, but my feeling is until women stop coming into my office feeling their own lump, then I'm going to still advocate for breast self-exam. So if it's something that you weren't born with or it feels abnormal, then you need to get that checked out.
Thank you, Dr. Hampton. Thank you for sharing your expertise, your experience with us. LaToya, thank you so much. We're praying for you tomorrow. Please keep in touch and keep us posted on your progress. At this time, we'll bring back in Nicole Jackson-Williams, First Vice President of Xi Omega Chapter of Alpha Kappa Alpha, to give our closing remarks.
Okay. Thank you so much, Tanya. Thank you so much, Desiree. And especially thank you so much, LaToya.
Thank you.
We are praying for you and we are wishing you the very best. And we cannot wait to hear about the victory that's going to come. So
Right.
thank you
That's
so
right.
much.
Amen. Thank you.
Dr. Hampton, thank you so much for just making it plain, helping us to understand what does triple negative breast cancer mean. And thank you to all of those who joined us tonight for viewing and for participating, for the questions, everything. It has been, I would say, a special time together. So thank you again. Please be on the lookout and check Xi Omega chapter's social media pages for our upcoming events. We will have more events coming up. Thank you so much again, everyone, and have an amazing night. Thank you.
Thank you.